Okay, now we are recording, so just let everybody know. Tampa, Florida. I'm not too far from there. South Carolina.
Is that Des Moines, Iowa, or Des Moines, Washington?
Yeah, I thought the same thing. Actually, I assumed Washington because that's.
I assumed Iowa.
Well, one of us is probably right. Iowa.
There you go.
You win. Oh, we do have somebody from the UK. Welcome.
Yeah.
Okay, well, I'm going to go ahead and get started so we have as much time as we possibly can. This is Katie Wright, the director of the VEDS movement, and this is being recorded, so you will be able to access this later. We will send out a link to the recording in the next couple of days. This is our series called Charging Forward Virtual Medical Symposium Series, and we designed this to give you information about VEDS or Vascular Ehlers-Danlos syndrome from our professional advisory board and other leading medical experts. Oh, there we go. And if you haven't heard of us already, we are the Foundation's VEDS division. Hopefully you have realized that when you registered for this webinar, but we are very excited to have you. And if you haven't checked out the vedsmovement.org to see the information there, we hope you find it helpful and resourceful. I'm very excited tonight to introduce Dr. Peter Byers. Tonight's webinar is on creating a care team for VEDS. Dr. Byers is a medical geneticist at the University of Washington, and I believe he's been involved in research in VEDS for about 40 years, give or take. And he is also the director of the Collagen Diagnostic Laboratory at the University of Washington. So before we continue and hand it over to Dr. Byers, I just want to remind you that if you have questions during the webinar, go ahead and put those in the Q&A box, not the chat box. I will be monitoring the Q&A box for questions. And you can do that anytime during the presentation. We will have plenty of time, I think, to visit the Q&A, and several questions were also submitted ahead of time. So I will go ahead and pass it over to Dr. Byers.
Thanks. Let's see, Katie, that's great. Okay, terrific. To figure out whether I must be able to control this as we go.
Maybe right click and back or.
There we go, great. Okay.
Perfect.
So as Katie said, I'm a medical geneticist at the University of Washington. I've been here since 1974, and I came here to train in medical genetics after having been at the NIH for 3 years, and before that, the University of California at San Francisco in an internal medicine residency program. And I came here to train in medical genetics because during the time that I was at the NIH, it became clear to me, at least, that studying people who had genetic disorders had two outcomes to them that we could do. One was we would make a difference for people, and the other was that there was some fundamental underlying biological, what, for want of another word, I call truths that we would uncover in doing this. And I think that one of the lessons that almost everybody who has taken this route, whether it be with VEDS or Marfan syndrome or brittle bone diseases or any of the other kinds of things, both of those things are really things that happen as a consequence of doing this. And one of the rewards is actually being involved in the community that we study. And I've been involved in the vascular EDS community for a long time, also with the osteogenesis imperfecta community and the Marfan community. There are a few more satisfying things that I do than going to one of the annual meetings of the group. So in talking about what is really, and I will come to this in a minute, is the constant issue of my doctor doesn't know anything about vascular EDS, is how can we combat that, and what can we do to make sure that everybody who has this is comfortable in a medical environment and feels safe in a medical environment. And we developed some years ago the concept of a care team, and we'll come and I'll give you a picture of what that looks like in a few minutes. But I wanted to talk about the who, what, where, when, where, and why of care teams, and you'll recognize that those are the elements of a topic paragraph in the newspaper or in anything else that you want to do, and that kids are taught those in talking about things. So I thought I would use that as a way to go. But one of the things that we're interested in is the idea of transforming my doctor doesn't know anything about VEDS to my doctor doesn't know everything about VEDS. And you think about the difference that makes. I think that you get a sense of how this really makes a difference in how you can work with the physicians around you, and how you create something that is a safe environment for people. So what do doctors actually know about vascular EDS? Well, this is a very difficult question to answer. And often you would start off by saying, well, they really don't know anything about vascular EDS, except maybe in medical school they learned the name, and they actually learned it as Ehlers-Danlos syndrome type 4 and not the vascular form of Ehlers-Danlos syndrome. So the answers to these kinds of questions will be very different depending on who you ask. If you talk to a medical geneticist like me, who's used to dealing with complex conditions and actually sees a lot of people with this condition, then you can get a fairly, I hope, a reasonably articulate view of what's happening, have a plan in mind about how to work with people and what to do. If you talk to vascular surgeons, you hear about aneurysms and dissections, and they may or may not have had much experience with it, but they know to be a little worried about the process. General surgeons or GI surgeons may know about bowel rupture, but they usually think about bowel rupture in the context of other sorts of things that happen, Crohn's disease, diverticulitis, and things of that sort, or cancer. Spontaneous pneumothorax, you think about pulmonologists will know about that, and this may be part of the differential diagnosis that they have. Interventional radiologists will know about carotid cavernous sinus fistula. The point about this slide is that for a general internist or a family medicine doc or even a pediatrician, they are actually used to dealing not so much with people with vascular EDS, but they have experience with aneurysms, with people with aneurysms, and they will know how to refer to people who are expert in taking care of things. They will have had some experience with people who've had bowel ruptures, and certainly in the adult population, perhaps more than the pediatric population. And they know who to refer to and how to work with people. They know what the acute evaluation represents. Spontaneous pneumothorax is not uncommon among adolescents, and so most general physicians will know something about that. Carotid cavernous sinus fistula is a very rare event. Most people don't have much experience about that. But the point about this is that if you ask a physician who you're approaching and thinking about as being your physician or talking with your primary care physician, and you say, how much do you know about vascular EDS? The answer is going to be, well, I really don't know very much about it. I think how to spell it. I heard about it in medical school. But the reality is that they do know things about the complications, just not in the context of this specific underlying diagnosis. They do know about aneurysms and dissections, about bowel rupture, about spontaneous pneumothorax, and the kinds of complications that we worry about in taking care of people. So I think that's a very important thing to keep in mind when there is that sort of underlying feeling, my doctor doesn't know anything about vascular EDS. And the answer is, well, think about it. They do know about the complications that can occur, just in a different context. So when we think about who is going to be involved in this, so the first thing is you. That is, the person who has vascular EDS. And what you will find is, and I think this is very common in people who've had the diagnosis, who've talked about it, have integrated into the programs like the EDS program with the Marfan Foundation, with the prior iterations of the Vascular EDS group, with the Ehlers-Danlos groups, that you are likely to know more about vascular EDS as a specialty. You will know far more people than your physician knows, and ultimately than with most clinicians that you encounter. But you can't translate that into ways of taking care of yourself, except in the very general sense. And you need collaborators, and that's your healthcare team, to translate your knowledge into action in the context of known complications of vascular EDS. And I think the important thing to recognize here is that the reason for creating a care team is so that you are not alone. You don't feel that you're alone in this context. So why do we do this, and where? And the answer is, for most people don't live near the vascular EDS experts. And as a consequence, care is local. And that is, we're trying to make it so that you can have a group of people who work with you, who are in your community and have contacts outside that community if they need them, to be able to provide the care that you need. And when do you do this? Well, probably as soon as you can after the diagnosis is made. And this is why I say that care is local. I've put stars, red stars, in places where I know about people who know a fair amount about vascular EDS. So, for example, Shireen Shalhoub, a vascular surgeon, and I are in Seattle, which is in the upper left-hand corner of the U.S. map. We are the furthest north major city in the country. We also have the lowest COVID rate of any of the major cities in the country, just so that you know. The Mayo Clinic is here in Minnesota. The Cleveland Clinic and Case Western Reserve University have people that are there. Heather Gornick recently moved from the clinic to Case Western Reserve. Anna Mitchell is a geneticist there who trained with us and knows people. Hal Dietz is here in Johns Hopkins in Baltimore. There is an emerging group at Mount Sinai and also at Cornell Weill Medical School in New York City. Mark Lindsay is a cardiologist in Boston. Lauren Lacroix is another one who's had some experience with it. Alan Braverman is a cardiologist in St. Louis and follows a number of people. And then in Houston are Shane Morris, who's a pediatrician who's very interested in following kids with vascular EDS, and Diana Millowitz, who's been one of the people who's done a lot about gene finding. So what you see is that, these people, if you happen to live in this portion of the United States out here, you're a long way from somebody who's recognized as an expert, but you are likely to be fairly close to people who are recognized as having experience in the sorts of things that can happen. You have vascular surgeons nearby, cardiologists, pulmonologists, and GI surgeons who can all be of help in the right circumstances. As you get to more populated areas, there are people that are a little bit closer, but it's still not everywhere. And that's why we say that care is local. And that is, in order to be able to create something that is useful for you, you really have to work to find people in the local community. So this is how we sort of pictured this, and what and who is involved in the situation. So you, or the patient, is this large yellow circle. And you're the person of greatest importance in this circle. I don't know whether you see that, but I hope that goes away. And your primary interactions are with your primary care physician. So a primary care physician can be a pediatrician, can be a family physician, could be an internist, or in some circumstances might even be one of the concierge doctors that would be in this area. We haven't had much experience with the concierge physicians, and I don't know, I think occasionally that, maybe this is not what they want to do, but I think that they're worth looking at, because what we're interested in is the relationship between you, the yellow circle, and the primary care physician here, who helps coordinate care and is on call and is able to make sure that things work for you. So the person that you interact most with is the primary care doc. And the point about that is, well, what do you do with the primary care doc? Well, you set out a plan, and you have a plan for action, so that in the event that something happens, you know that if you call your primary care physician, that you will have access, that the primary care physician can make contact if you need to with a cardiovascular or general surgeon, if you need to with a cardiologist or a pulmonologist, or any of the other people that might be important in intervention. I think it's probably helpful if in the course of this that you make appointments to go visit the candidate cardiac or vascular surgeon or the GI surgeon, and if you can, the cardiologist and pulmonologist with whom you might need to have interactions at a later time. I put the geneticist here because I am one, but also because I think that in the overall sense, the geneticists are more likely to have a broad view of what's happening and may be able to help provide information and really be able to help sort out where to go. Sometimes help choose a primary care physician in the neighborhood or in your neighborhood, and then help provide the primary care physician and the vascular surgeons and the cardiologists and pulmonologists with the basic information about, what are management plans, what do you need to learn about, and how do each one of those people help you get through any kind of thing that's going to be a problem. And I think, and Katie can talk about this at some point, is that the idea of planning ahead really is very helpful, because it lets you sort of sort things out and have an idea about what to go and what the circumstances are under which you would need to have that consultation. I think a number of people in the audience may well have had, have been told, well, go to the emergency room. Well, that's all well and fine. But if you do it through your primary care physician and that person calls ahead and says, listen, Joe is coming to the emergency room. He's had such and such, or Sheila is coming to the emergency room and she's had such and such. This is what you need to do. Here's the evaluation that you need to do. And she or he has vascular Ehlers-Danlos syndrome, and here are the complications that you can expect, and here is the workup that needs to be done. That's very different than walking in the door of the emergency room, even if you have all the materials that Katie has been very active in putting together in terms of the emergency kit, and saying, oh, by the way, I have vascular EDS, you need to do something, or having one of your family members say that. So having that contact is extremely important if you can manage it. And then having the specific surgeons or the specific people in contact are also very helpful, so that the primary care person can talk to this person or to this person and say, here's what's happening. We need your care at this point. And we put this together, and there are a number of things that you see here. And when I drew this diagram, I had particular things in mind. And one was that you are the person that's in contact with everybody here, that you are the big circle in the game, and that everybody else is working with and for you to make sure that things work well. And I realize that's a sort of maybe wishful thinking at one level, but this is the intent of this kind of thing. And so you're the big circle, and everybody else is somewhat smaller circles, even though at any given time they may be a major contributor to health and maintenance. There should be communication from the primary physician to each of the other ones, and ideally there will be communication, among all the other people at different times. So I think one of the things about this is to remember care is local. That is, if you live 100 miles away from a major medical center, you need to have somebody in your local environment who is your advocate, who helps you take care of yourself beyond you, and is able to integrate you into the local medical care system, and then make decisions about what happens in the case of an emergency. It's helpful to have somebody that you can go to on a periodic basis just to check in and check out. And if you have, so for example, in the Washington, Alaska, Montana, and Idaho, Wyoming area, we have people who come to Seattle on a periodic basis for more complete evaluation. Although increasingly we're seeing that kind of evaluation occur in the local community with consultation with Shireen, the vascular surgeon, with me, with the local cardiologist, to make sure that things are going well and that there's nothing untoward happening, and to answer questions about, well, what would be the next step. So care is local, communication is vital, and this is you're creating a plan for ordinary care. Just because you have vascular EDS doesn't keep you from having the flu or a cold or even COVID, or any of the other, diabetes, many of the other kinds of things that are common in the population. Having vascular EDS doesn't exclude them from your environment. And what's most important is to create a care plan, a plan for extraordinary care. That is, in the event of, if I have sudden pain in the abdomen and I'm not sure whether I have ruptured an artery or my bowel has ruptured, what do I do? How do I get there? And that's a plan that's made with you, between you and your primary care doc, in consultation with the people that you would end up seeing. And so here are the criteria that you would use, and here's what you would do. One of the things about this is that you see and that you'll recognize is that help comes from around the world. We've been on phone calls, or now more recently Zoom calls, with people working with people who have the different complications, with people from around the United States. And more recently, we had a Zoom call that involved somebody from Belgium, two of us here in Seattle, and the patient and the primary care person who had a different form of Ehlers-Danlos syndrome in Miami. So with rare or relatively uncommon conditions, you can count on having care from around the world. So how do you do this? What do you do? Well, I think that there are two ways. You start with your primary care person. And sometimes it won't be a physician. Sometimes it'll be a nurse practitioner or something like that, who is actually, very capable of getting you involved with everything else. With that person, you ask about recommendations for the important people that are part of there, and with them, then arrange an appointment to see that person or those people. If there are other people with vascular EDS in your community, ask them. Ask them if they have successful interactions with other people, who works, who doesn't work, and what to do. And that's really, and I would be kidding you and kidding myself if I thought this was easy. And it may not be, and you may have people who say, oh, I can't do this. I don't know anything about this. And you're telling them, well, yes, you do. There are so many other things that you could, you can read. We can get you the information. We can get you in contact with people who know a lot about this and who are happy to support it. Sometimes that's just not going to work. It just is beyond what people are involved in doing. And they don't want to have to be in a position of making these decisions. And, don't let that stop you. Go to the next person and find, and ultimately, I think you will find somebody who can do this. So that's the outline. I think that the most important figure is this one, and you can keep this in mind and think about this as what a care team is, how it works, and where you are in the context. And you are right there in the middle, and you are the focus of everything here. So that's me. That's my email address. I'm happy to answer questions. I'm sometimes really good at answering them quickly, and sometimes I'm not very good, but I will do my best. If you introduce yourself and tell me what the story is, don't make it, don't give me a novel, give me a short story about what the issues are, so that I can return with a few short, pithy remarks and help you on your way. So that's where we are. I'm going to go back and leave it here and then open things for questions and see where we can go.
Perfect. Thank you so much, Dr. Byers. And I know we had a lot of questions submitted ahead of time, and we do have a few in the Q&A. So I think I'm going to start with some of the ones that were submitted ahead of time.
Mhm.
So if we don't get to yours right away, if you just submitted a question, hang tight. We're going to get to as many as we can. Okay, so you're talking about the types of, and I love that you left this diagram up. I think this is going to be really useful for answering these questions. What specific doctors do you need to see once diagnosed? How soon do you need to see them? And particularly given the long waits to see VEDS specialists sometimes, what do you recommend that people do while waiting to be seen?
So I think that that's pretty straightforward and it's answered here. And the answer is the first person you go back to is your primary care physician or your primary care person. And as I said, I think sometimes the nurse practitioners, physician assistants can be extraordinarily useful in this context and do a great job. And work with them to now identify people. Often, if you come on the diagnosis because you've already had a complication, then you may have somebody. You may have a general surgeon because you had a bowel rupture, or you may have a vascular surgeon because you were identified as having a vascular event. And maybe that person is local, and if not, then maybe that person would help you and find somebody who would be more in the local area that you can deal with there. Same for somebody else. Cardiologists often do follow people with vascular EDS and help coordinate doing the periodic studies, although it depends a lot. And more often, the screening studies, looking at the vasculature and things like that, are coordinated by your primary care person, and then with the supervision of somebody or the recommendations of people who are looking at, particularly at the vasculature. So when? Well, do it sooner than later. If you put it off, it's going to be more difficult because you're not going to be sure why you're doing it. If you do it in the moment, you say, you know, if I had just had something like this available when all this was going on, I would have a much better, I would have felt much better and I would have felt much more secure. And so the objective really is to get you feeling secure about what's going to happen in the future. And the vascular surgeons, general surgeons, cardiologists, pulmonologists are people to be there. You don't have to load up with everybody because you're going to expect that your primary care doc is going to be the person who's going to help you do that.
Got it. Thank you. And we talked a bit about emergencies, and we do have a lot of resources on the VEDSmovement.org that you mentioned for emergencies, but of course, like the role of the care team is so important in this. Is there a certain doctor's phone number that you would prefer to be put on a medical ID bracelet, if any? Meaning the cardiologist, the neurosurgeon, the geneticist, etc.
I would put the person's number who knows you best. And who knows the most about what your condition is, so that that person can then send somebody off somewhere else. But I think having somebody that will be there, who will answer the phone, is the one to have there and the one to inform. If you have, if you've had a long-term relationship with us here in Seattle, for example, because you've come to see us on a regular basis, you can certainly put my number or Shireen's number, Shireen Shaloub's number on there. But I think that it's somebody local is best, so that you have somebody who's going to call the person that knows you best.
Okay. And we talked a little bit about maybe conducting the interview with the doctor or talking to the primary care physician. What do you recommend that conversation look like? We have somebody who's asking about how do you talk to your care team about coordination of care? what's important for each physician to know, and how do you even begin?
Well, I think that's a very, it's a very interesting and it's a very sort of insightful question. And I think, Katie, you can respond to this as well, because you've really had the experience of trying to do it. When you go to buy an appliance, you go and you look at different appliances, you look it up in consumer reports, you see what it's like and things like that. And in a sense, that's exactly what you're doing. You're going to see whether you are compatible with, whether you think that you and the person that you're interviewing can form a reasonable and trusting relationship. And if the person says, well, I don't know anything about this and I can't do this, you take that at face value. It's not a personal insult. It's not, directed personally. It's just an evaluation of her, his own self-evaluation. And what you might ask at that point is, well, is there somebody you can recommend? Is there somebody who you think might be able and willing to do this? And the person may say yes or no. But I think the thing is, you're there to really say, I'm looking for somebody who can work with me in this situation. I'm able to give you, to help you understand more. I can help you get information about what to do. I can help you get the way in which care plans are constructed. And we have information from the foundations, we have information that we have in different places for what things we do. And I'm happy to give you that. And I know that you're not going to know as much about vascular EDS as some other people, but I think that you've probably had experience with some of the complications that people have. And so it's, I have not been in the situation. So, I mean, I've been on the recipient end of it, saying we would like to come see you every year. And I say, of course, but, and I think that it differs. It will differ dramatically among people. And some people just are not comfortable because they're spooked in various ways. And you don't want somebody who feels that way. I mean, you want somebody that says, gee, of course, this is very interesting. I would be delighted to learn with you about what to do, to learn from you, and to do this in a collaborative fashion.
Yeah, I think it's a great point that you bring up, and I have had to do this a few times. I think for me, I always try to call ahead. I don't, if there's any opportunity for me to call ahead and leave a note for the doctor that I'm interested in potentially, developing this patient-doctor relationship with, I ask to leave a note for the doctor with the name of the condition, and I always, have to spell it for the, but it's fine. And I say, please make sure, it's very important that this doctor knows it's vascular Ehlers-Danlos. So I make sure to do that and ask really, this is what I need. Are they willing to work with me? And that really saves me. It has saved me before the copay or the cost of the appointment, to find out that someone's really not interested in becoming my primary care physician or other specialist. And I think that's how I ended up learning that lesson, when I could, is that there were a couple appointments I had where the doctor didn't realize ahead of time that I had VEDS, and they were not interested in learning more or being involved in that. So I paid for a copay basically for that appointment that I could have saved if I had called ahead. So anytime I can, I do try to do that, and I try not to take it personally, like you said. I think it is important to have somebody who's truly interested in taking care of you. If you have somebody that's kind of wishy-washy, you have an appointment with them and you're not quite sure that it's the right person, if there's somebody else around, I don't think there's any harm in trying to find somebody else that you're comfortable with.
And I think also use your primary care person to help you make that appointment.
Definitely.
I think that, a cold call is like a cold call at the emergency room. It's, you're already working against the barrier. And so have somebody else help you make that transition.
Great advice. I'm going to go back to the phone number question because somebody did put this in the Q&A as well. We were talking about having the number of a person on your care team on your medical alert bracelet. Do you think that somebody should have the cell phone number of their primary care physician? And do you know if primary care physicians usually do that?
Well, some will, some won't. I think the answer is ask and say, I need to have somebody on my bracelet, and what's the best way to do it? Ideally, we'd like to not use the office number because it goes through all kinds of things. So, are you willing to share your cell phone? And for primary care, you want to be able to have that. You want to be able to contact your person directly, or at least be able to go through a switchboard that's going to get you to the person right away, or get your family member right away to the person. So when you're interviewing the people, that's another one of the things you want to know. How directly can I get to you? And again, for most of the emergency situations, you'd like to start with your primary care, have them get the things going, and then have them get in contact with the other people. And in the way medicine's practiced now, many of them will be in groups as opposed to individual programs, and so you may have more than one person that they would contact.
Okay, thank you. And we talked a little bit earlier about, you mentioned concierge physician. What is that?
So there are a number of physicians who have gotten tired of 10-minute appointments and doing things like that, and would like to actually they would like to be the Marcus Welby, for those of you who are old enough to remember Dr. Welby and Marcus Welby, or they would like to be the old-time doc who actually has enough time to talk with people and to work with them about working out things. And this is called a concierge practice now. Usually, they're often internists. I don't know whether they're pediatricians. I don't know about the family practice people, but they set aside more time. Usually it costs more. That is, they will take insurance, but there's often a fee that's associated with it. And you sort of buy into their practice to a certain extent. I've not had much experience with them. I think it's, we're, as a geneticist, we practice in that environment in the sense that we see people for an hour at a time. We have continuing, fairly long-term relationships with people. And it has a very different feeling than, I pop in for 10 minutes because I have a single problem. So it's a way of having somebody who sees you as a person, who sees you again over time and recognizes things. I don't know, and I haven't talked with our people locally about whether this works. I think we've had experiences where it doesn't, but I don't know how many times we've had it so that it does. I think it's worth a try. You have to know whether it's something that you can afford to do financially as well.
Great, thank you. Someone says they have their history and doctor's info written on a paper tucked together with their cell phone. Do you think that is just as good or better than a medical bracelet?
I think it's one of the ways to do it. I think, when when you come into an emergency room, or something happens and the EMT people come because you have suffered an event at home, they will often ask, or they will look for things. They look for bracelets, and they look for necklaces that have a medical alert thing. They will sometimes look in your wallet for a card, and so the Marfan Foundation has a card. We've put together a Vascular EDS passport that's available, but it's a more complicated kind of fold-out sort of thing. I think that people sometimes you can have an entry, you can have information on your cell phone, and you can give that to somebody, and they can see what's going on. Or having paper in your cell phone folder may be also helpful. I think anything that you have really that is information that says, this is what I've got, here are the kinds of complications to think about, here are the kinds of things that need to be done is very helpful to have. And to have it in any of the ways that you can communicate it are useful.
Okay. And we've got a lot of questions here. Do you think that a dietitian should be on the care team for vascular Ehlers-Danlos?
I think you get to the dietitian through your primary care physician. I think that I didn't, I could have put a dozen people around here, podiatrists because of club feet, all kinds of people. But I think I designed this in such a way so that it was the people who are going to be the people that need to be reached in an emergency. So this is really a safety net. The care net is more extended, and the care net will have other people. I'm not enthusiastic about having more and more medical visits. I think that the more you can do through a centralized source, the better off you are. I think that if you can do that and have dietary work, diet's important. We know that. And so having somebody like a dietitian available, seeing somebody is great. And maybe your primary care person is the one to get to that person.
Great. And we've got some other questions that are sort of related to care team, but also some are related to care. Are you good with asking those? Okay, great. So let's see. So for someone who has a history, whose family has a history of AAAs, and which has been a cause of death in many cases, but for them, their diagnosis is new and they have no diagnosis or history of incidents related to VEDS. Is there anything different about their plan of care or developing a care team, do you think?
No, I think that once you have a diagnosis, so if the diagnosis is established by having a genetic diagnosis, that's enough. If you're young enough so that you haven't had the opportunity to have complications, it's a good time to get people in place, although it would be a little more difficult to do because you have to have anticipatory guidance as opposed to the experiential guidance that you have if something has happened. And that's all a little bit unnerving, but it still is a good thing to have available. AAAs are abdominal aortic aneurysms are common, are fairly common in the population generally, and we would want to know whether those were specifically seen in people who had a genetic mutation or whether it was something else in the family, which it can be. We think that those are also have a significant genetic component. And so they may or may not be the indication of having vascular EDS in those people. You can clarify that if this is a specific question from one person, and if it's clear that everybody that had the AAA also had a COL3A1 genetic variant that was thought to be pathogenic, that as well. Okay, so that's part of it, and it would direct screening to making sure that to watch your abdominal aortic aneurysm as well as everything else.
Yeah, I guess that is the important factor then is making sure to get set up with physicians still on the care team for screening purposes.
Yeah, exactly.
Okay, great. And do you have any recommendations for providers associated with OHSU? Is that Ohio State University? Was that on your map?
I think it's Oregon Health Sciences University. Health and Sciences University. Ohio State is OSU.
I apparently am not good at that, those acronyms, so my apologies.
So Katie, Catherine Holmes there is a cardiologist. She's a pediatric cardiologist. And she's the one I would talk to about this, to see who she has been referring people to there. We are 180 miles from there. We're happy to see people and then to help with coordination. During this time, I actually have a license to practice telemedicine in Oregon, so it's That's another way of doing things, and we're happy to do that as well and help you set this up. But ideally, so I think I would talk with Dr. Holmes of OHSU. It's Catherine Holmes, Holmes. And she's a very good resource for these things.
Thank you. And if anybody hears my cat in the background, I'm very sorry. He's not happy about being locked out of the room that I am in.
You can invite him in.
Oh no, he will take over this webinar. So someone else asked what a AAA is. That is an abdominal aortic aneurysm. I think you answered that one. And there's a couple questions here that are very specific. So I'm going to ask this person to submit that question to our Help and Resource Center, which we'll have a link for at the end of this, but it's thevedsmovement.org/ask. I think that will allow us to really facilitate a conversation with you, Dr. Byers, or your email is also on this webinar at the end. Okay. So I just want to make sure we're not ignoring your question, but I think it's a better kind of one-on-one type of question. So if you have a variant of uncertain or unknown significance that was diagnosed before, how do you get any updates on that or find out if it's no longer being followed by genetics? Their testing was done at the University of Washington.
Well, if it's done at the University of Washington, the best is to, and if you're at the University of Washington, you would come see us. If you're not, the best thing is actually to send us a note and ask us about it. We just, for somebody with a Marfan diagnosis, we had a variant of uncertain significance in fibrillin that we recently updated in response to the request.
Great. And I think we're going back to the AAA. I think this question might be best for a vascular surgeon, but I'm going to give it to you as well. What is your preferred method to screen for an abdominal aortic aneurysm?
Well, it depends a certain amount on what you're interested in looking at. Are you interested in looking to see if there is one there? A lot of that screening is done by ultrasound. So that's the same kind of thing as is done with an echocardiogram if you're used to that, or if you, for looking at the fetus during pregnancy. And the ultrasounds are actually quite good at looking at the diameter and making sure that the diameter is good, looking to see if there are aneurysms in the area. They're not quite so good as telling what vessels are involved. They can usually see if there's been a dissection in the area. If there needs to be more detail, then the one that has the best resolution is actually a CT with contrast. So that's a radiologic or X-ray CAT scan. A little bit less, but okay, is an MRA or magnetic resonance imaging with angiography. If you know about, if you've read the literature or read concerns about things, you would worry about the use of dye injection, except that that's really arterial dye injection that was used to be done under relatively high pressures. We're concerned about those because the high pressures can create local enlargement in aneurysms in very rare instances. But this is introduction of the dye into a vein, usually in the arm, and then following the dye as it goes through the body, and then looking at its the involvement and looking at what the blood vessels look like all throughout the body that way.
Great, thank you for that. And we do have a previous webinar available on our website from our E3 Summit last year. So if you check that out, we have a link later for previous webinars, but we do have that one available as well.
Great.
If you need more information. So I have a two-part question for you. I know you mentioned that a geneticist is obviously important on the team. What is the specific role of the geneticist? I think you did talk about that, but I want you to talk about it again. And are you doing telemedicine, specifically you?
Right. So I am, but we're limited to some extent. Some states just allow it anyway. For others, we have to have either be registered or be licensed. But yes, we do. In fact, in the month of February 2020, the University of Washington had 250 telemedicine visits, and they were scattered over about 50 to 60 physicians in the medical community. In February of 2021, there were 25,000 telemedicine visits at the University of Washington, and the vast majority of all physicians and some patients were involved. Those are almost all locally. We have applied so I have licensure or permission in Nevada, I think Wyoming, Montana, Idaho. I don't know about Alaska. I don't think Alaska, and Oregon, actually. California is a little bit more complicated, but in some cases it's not necessary. And in some instances, it may be something to do in the context of doing it with a physician, so that it's actually a physician-to-physician call, but with you present there. So what does a geneticist do? Well, some people say not much, but actually you have to realize that geneticists are a little bit unusual in the world of medicine. We think that medicine is actually a subspecialty within genetics. The pediatricians think that genetics is a subspecialty of pediatrics. Medicine thinks it's a subspecialty of medicine. Surgery doesn't think it exists at all. Things of that's a joke, just in case. But our role has always been to explain complex conditions that have implications for the family to people, to work out diagnosis plans for people who are at risk and to explain who is at risk, to talk about the natural history over time, that is, what people can expect, which is usually much more complex than you would get from most other people who don't necessarily know about it, to help you identify primary care and specialty care physicians who would be involved in your care, and to help interpret and explain what genetic testing means and how it works. We spend about an hour with a family, and so it's a much more comprehensive visit than you would expect to have with most other people. And it usually is, for most of us, a conversation as opposed to a set of questions and maybe a few answers at the end, and a discussion about what's needed and what to plan for in the future. And we look at things, for a geneticist, everything is genetics, genetic, including things like getting hit by a truck. That is, you get hit by a truck because you're clumsy and you stepped off and you stepped sideways when you meant to step forward or backwards. So there's a genetic contribution to that because you have increased joint mobility. And therefore, getting hit by a truck is a genetic condition. But we're serious about genetics being really very important. For a long time, people were saying that, if you want to go into a specialty where you have no treatments, neurology and genetics are the other places to go. And the answer is that's not true anymore. We really are. We help aggregate families to be able to look for medications that are helpful, to be able to work out ways to follow people, to do things of that sort, to know what the history is, to recognize that different mutations have different implications for people, to help understand what a variant of uncertain significance means. It means that we really don't know whether it's causative, and to explain the logic and what what people can expect at a level that you can expect to understand, and to do it in ways that you have a chance to ask questions about. We are the Marcus Welbys of medicine at this point as well, I think.
Thank you. I'm
Or at
gonna
least some of us are.
I'm going to ask one final question because we're coming up on 8 p.m. So this is kind of a, I think I understand the feeling behind this question. And we talk a lot here about, you know, the patient is the biggest circle here, but the patient is also kind of responsible in this case for making sure to communicate with the different doctors and potentially educate. This person's question is, will anybody with VEDS be able to be a patient with the care team? I think that's around, you know, having potentially more information about VEDS than your care team does.
Well, there are, I mean, I guess there are a couple of things. The first is the care team is not a specific set of individuals. The care team is centered on you, and you create your care team. So that's the first part of it. And I'm not quite sure which way you were thinking about in that question. So the care team for somebody who lives in Nebraska is going to be different than somebody who lives in New Mexico, than somebody who lives in New York. And this is a model of what a care team will look like. So that's important to think. That's important to think about. I don't think this is limited to people who have vascular EDS. I think this is a model that is important for people that have uncommon conditions. We've used this as a model in Marfan syndrome, but we think that for anything that requires coordinated care among a number of individuals, this is the kind of model that's important. And you know, ideally, this is how all primary care works, but people don't think about it this way. And I think this is only, I think by looking at this, you'll say, you know, I knew that. This isn't anything new. It's not. I mean, but it's just a way of diagramming what happens. And so everybody can participate in these sorts of things. I think you will find that often if you have multiple family members in a locality, that having the care team involved with all of those individuals and having all those individuals involved with a single care team is often very helpful, because you don't have to re-educate people and don't have to help them educate. So that's another aspect of what a care team does and how it works for people. But I think, you know, it's really there is as a picture for you in your mind about how you're going to organize things around you. And, you know, I remember taking this as a model for Marfan syndrome a few years ago when we were talking about care for people with Marfan syndrome who have, like people with vascular EDS, multi-system involvement. They need to see ophthalmologists, orthopedic surgeons, cardiologists, maybe see cardiac surgeons. But it's the same, you know, the model is the same. I think for those of you who have kids and have kids that have had complicated things happen to them and have gone to one of the major children's hospitals, this picture should be familiar. I mean, the picture may not be, but the model is familiar. And that is, you go and you see in a coordinated fashion people in several specialties and make an effort to have you go on one day to see people if they've got their act together, so that you're not going to the doctor, you know, once a week, every week of the year, but you have your care clustered both spatially and physically. And that's what this is about. And it really is a way of, you know, getting into your own mind. How am I going to manage all of this? How am I going to manage this for myself? And what is it going to be? How am I going to be comfortable with everybody around me? It's a way of just putting that down on a piece of paper and saying, this is how it's going to work.
Yeah, and I think this question really speaks to potentially the exhaustion of trying to get a care team or trying to find a doctor, and not maybe that frustration of, you know, not finding the right people at a certain time or something like that.
Yeah.
So
Yeah,
it's a great question. I think it's important because there is a certain amount of exhaustion that can happen when you are trying to. It isn't easy to do, and this is certainly the ideal and what we should work towards. But doing some self-care during that time, if you're having challenges, that I think is important too.
Yeah. And remember, you will know as much about vascular EDS, but there are things that you can't do.
Yeah.
And that's where you need the involvement. And I think the most important thing is finding one person that you're comfortable with as a primary care physician or primary care person, and working with them to identify the others. Don't take it on yourself to identify the others independently if you have somebody that you can trust.
Great. Thank you so much, Dr. Byers, for presenting tonight.
You're very welcome. It's a pleasure.
And
it would be even nicer to be able to see people.
maybe next time.
Maybe next time. Yeah.
We do have I have a couple slides to share with everybody before we go tonight. So I'm going to switch screens here and let's see. There we go. So we went through the Q&A. Again, thank you everybody for participating, and thank you, Dr. Byers, for also participating tonight and for your dedication to people with VEDS in this community. So we will be sending out the link to this recording when it is available. And we have a few upcoming things I want to share with you. The first are a couple webinars offered by the Marfan Foundation. One is a personal perspectives panel with dads with VEDS, Marfan, and Ehlers-Danlos. This is, I think that's actually next week, March 31st, 7 p.m. Eastern. And then following that on April 14th, there's another webinar with Dr. Polsani on aortic imaging and answering your questions about aortic imaging. So I think there was actually a relevant question to that tonight, and for sure register for that webinar. Other webinars that we've done in the past, both medical webinars and empowerment series, which are quality of life, those are available on our website at thevedsmovement.org/webinars. And we have a couple other upcoming events. If you haven't joined one of our benefit bingos yet, we have a lot of fun at these events. Sometimes they're monthly, sometimes every other month. Our theme this month or next month is national parks. And we will have lots of fun facts about national parks, and we really do have a lot of fun. So I hope to see you there. That's April 8th at 7 p.m. Eastern. And then of course, save the date for our annual conference, which will be virtual this year, July 8th through 11th. So we will have more information on that coming soon, but for now, save the date for that weekend. And if you haven't heard about our Kids Club already, this is a new thing that the Marfan Foundation is offering for kids ages 9 to 12 with Marfan, VEDS, or Ehlers-Danlos or related condition. We meet on the third Thursday of every month at 7 p.m. Eastern, and it's really just a fun get together for kids to join other kids. They play games and just have a lot of fun. So you can register your child for that at thevedsmovement.org/kidsclub. And finally, the Marfan Foundation has kicked off its Walk for Victory season. These are obviously pictures from previous walks and Team VEDS at the Walk for Victory pre-COVID-19 pandemic, but we are having a lot of fun still, a lot of times virtually. So I encourage you to create a Team VEDS at one of the Walk for Victories, or join an existing Team VEDS and help us raise vital funds for vascular Ehlers-Danlos syndrome. And if your question wasn't answered tonight, or you have additional questions, you can always reach out to our Help and Resource Center. Jan Lynch is the registered nurse in our Help and Resource Center, and she really is here to help. So you can reach her by going to thevedsmovement.org/ask. Thank you everybody so much for joining us tonight, and thank you again, Dr. Byers. It was really great to see everybody in the Q&A in the chat, and we look forward to seeing you soon.